Welcome back, everyone. Moving ahead to our third plenary session, which promises to be another enriching experience. This session will be chaired by Sister Maggie Jose. I invite you, Sister, on the stage. Currently, Sister holds the position of Principal at BCM College of Nursing, where her leadership continues to shape nursing education and professional development. She holds an MSc in Nursing from RAK College of Nursing, New Delhi 2006, a BSc from AIMS, New Delhi, and a GNM from Lord's School of Nursing, Kerala. Sister Maggie has been recognized for extensive contributions to nursing education within 24 years of teaching experience. She later served as the principal of Rasman School of Nursing, Shillong, and as a professor at BCM College of Nursing. Her career began as a ward in charge at BCM Hospital, Khairabad, followed by roles as a tutor at BCM School of Nursing and an assistant professor at Sahara College of Nursing. Accompanied her is our esteemed speaker, Dr. Monica Hendricks, ma'am, who will be shedding light on the topic Policy Making in Midwifery, Improving Maternal and Neonatal Health through Evidence-Based Regulations. Before we begin, I would like ma'am to kindly come upon the stage. Now I invite Mrs. Anamika Chaurasia ma'am to extend a warm welcome by presenting a live plan to both of our chairperson and speaker. Thank you so much, dear ma'am. Now I request Sister Maggie Jose ma'am to kindly formally introduce our speaker. Over to you, sister.
Good morning to all. Welcome back after a high tea. So, esteemed gathering, distinguished guests, and all the panelists, vibrant and dynamic students, the audience. I am glad to introduce about her leader, Miss Monica Rita Hendrick, a vibrant leader, a dynamic leader. A good leader possesses several key qualities which inspire and guide others towards a common goal. A leader has a clear vision of the future and inspires others to work towards that common goal. A leader who knows the way, who shows the way, and who goes the way. So let us invite Ms. Monica Rita Hendrick, the panelist of this, the speaker of this particular session, on the particular topic on policy making in midwifery, improving maternal and neonatal health. Over to you, ma'am, and all the best.
Thank you, Sister Maggie, for that introduction. Honorable Chairperson, all the guests of honor who are occupying the first seats, and all the students who are part of this workshop. So a warm good afternoon to all of you. So today I would be enlightening you on what is midwifery, how is it different from obstetrics, yeah, and enumerate the roles of midwives in improving health outcomes, examples of evidence-based policies in midwifery, especially in the state of Uttar Pradesh, the key components of policy making in midwifery, the challenges affecting the success of midwifery in India, and the strategies to overcome these challenges. So this is, okay. So this is the statistics. This is a very rough statistics for you to get an understanding. So our population is 1.46 billion approximately, out of which 22.2% of the women are in the reproductive age, And the requirement of an OBGY is 1:1,000. And we have an approximate of 70,000 OBGYs. That is about 40% less from the needed amount of, or the needed number of midwives or obstetricians that we need. So, can I ask the students a question? What is the difference between an obstetrician and a midwife? Can I have a volunteer, or should I pick you up from the group? What is the difference? What is the difference between an obstetrician and a midwife? There is no right or wrong answer. I understand that the concept of midwifery is pretty new. We may be confused. It is okay to, give me a wrong answer, but I need the confidence in you to get up and give me an answer. What is the difference between a person who finishes MSc OBG? What is the difference between a midwife? Are they the same? Okay, are they the same? MSc OBG and midwifery, are they the same? Yes? No? How many of you say yes? Raise your hands. They are the same? They are different. How different are they? Yes? Okay, I'm very glad she got up and she at least answered. Please give her a round of applause. But the difference wasn't all that clear, but I love the attempt. So the key differences are the training and qualifications. In BSc nursing, we learn obstetrics, we learn gynecology. Yeah? But to become a midwife, you have to learn a course called as Nurse Practitioner Midwife. So that course is about 18 months long. You can finish your GNM, BSc, and after which you should have 2 years of experience in a hospital which has obstetrics and gynecology, and you've been serving in that particular OBG ward or the labor room. Okay? So there is that particular difference. The scope of practice. The scope of practice, as you all know, those who finished MSc obstetrics, those who finished even BSc, work in the ward as a staff nurse. Whereas the nurse practitioner midwife, her role is a little different. She gives care for a mother during the antenatal period, the intranatal period and postnatal period, but it is a very woman-centered care. It is not fragmented care, it is very woman-centered care. And the approach is again very woman-centered and holistic, whereas a midwife, an obstetrician is, taking care of an obstetrician, be it a doctor or be it a nurse who has finished MSc OBG, the care that they provide is very different. It is very medical. It deals with complications. It deals with gynecological issues. Whereas midwifery normally deals with the normal process of motherhood, labor, and the postpartum period. Okay? So all of you got the difference between obstetrics and midwifery? So midwifery is again the care provided to a mother during the antenatal period, the intranatal period and the postnatal period, and the key characteristics are optimizing the normal biological, psychological, social and cultural processes of reproduction and early life. A normal obstetrician, an MSc OBG nurse, is not going to look at the psychological, social and cultural processes, Whereas a midwife takes care of the woman, keeping in mind she comes from a particular culture. She needs culture-specific care. Her needs, respectful maternal care, concern for the mother, allowing a partner to be with the mother, educating the partner during the antenatal period to help the pregnancy move forward. Timely prevention and management of complications. Midwifery concentrates on prevention and management of complications. It actually concentrates on timely prevention of complications. And once they identify a mother has some complications, they immediately shift the mother to a more specialized, higher level of care. Obstetricians deal with complications and more difficult labor and difficult pregnancies. And consultation and with and referral to other services is another role and responsibility of being a midwife. And working in partnership with women to strengthen women's own capabilities to care for themselves and their families is the key concept of midwifery. So, in one word, if you look at midwifery, it is woman-centered care. We are not looking, in normal care, what happens? The doctor is the main person. Doctor tells, you know, your labor pain has not started. Let me induce you. It is the doctor's decision. Of course, they get consent from the particular patient, but doctor is the central person, or the nurse there is the central person where we are just providing information. But in midwifery, the mother becomes the key person. They discuss with each other, they speak about alternatives, and the mother and the family gets to choose how she wants to be taken care of during the antenatal period, intranatal period, who she wants to have by her side, how she wants to be taken care of, and we try and make the entire process as normal as possible. I would like to quote an example to you. In those days, did we have obstetricians? Did we have doctors with complicated degrees, nurses with doctorate, double doctorate? Didn't women deliver normally those days? They used to go to the field, they used to go to collect firewood, and she used to deliver the baby and come back. So delivery and the entire process of pregnancy, humans being mammals, can happen in a very normal way. We need not give fundal pressure, we need not give medications, we need not go against nature. I'm not denying the entire process of, instrumental delivery or extended support for delivery. Of course, there will be complications, and that time we need higher levels of care. But sometimes what is happening right now is that too much of emphasis is given to medical care, medical support, which is not required for a normal case. Even if you look at a woman in labor, if you have conducted delivery, you wait patiently, you will see all the steps in the mechanism of labor happen. Internal rotation, restitution, the baby will come out normally. That's nature, that's God's way of getting a baby out. We need to intervene only when there are complications, and I feel a nurse, a midwife can do an excellent job at it, and unless and until a complication arises, that is when you need to refer the patient to a higher level. So that's about midwifery. And who is a midwife? So a midwife is not a person who has completed OBG as part of her requirements in her undergraduation, or OBG as a part of her requirements in post-graduation. She has to finish the nurse practitioner midwife course, which is actually very much in line with the International Confederation of Midwives guidelines. The syllabus is framed in discussion with looking at these guidelines, and it should be duly recognized in a country. So some years ago, we did not have the concept of midwives in India. It is a recently evolving concept. People have started thinking that, midwifery is better, having midwives is better, and I will explain to you why is midwifery better than an obstetrician. So why midwifery? Anyone, can you tell me why do you need midwifery? Why? I think now you got an idea. You know what is the difference between an obstetrician, an obstetric nurse, and a midwife. Why do we need midwives? One of the reasons already is depicted in the statistics. We do not have enough manpower. Our population is 1.46 billion. 80% are in the rural areas. People who finish high level of education do not want to go to rural areas. We want to be in the most super specialized hospital ever. So who is going to take care of 80% of the population who are actually at the rural level? So one of the reasons why we need midwives is to cater to the needs of the population. And that too in India, we all know that we are quite a populous country. So we need support. So that is one reason. Any other reason as to why do you think midwifery is essential in India? Please give it a shot, students. Why? Think, why? Why do you think midwifery is needed in India? Yes. Can you get up and, speak at your loudest possible voice? To reduce the complications. Okay. To reduce mortality, morbidity, both maternal and neonatal. Okay. Okay, good. So sometimes too much of interference, too much of medical interference causes a lot of complications. So letting the mother progress naturally will actually give us a breather and help in reducing a lot of our morbidity, maternal and neonatal morbidity and mortality. So the first thing is, the reason why we need midwifery is quality health services. In midwifery, what happens is that one midwife takes care of the mother all through her pregnancy. So a woman who visits the OPD meets the midwife and she keeps following up with her, and if everything is fine, she is the person who is with the patient till she delivers, till she reaches her postpartum period. So what happens, you become very confident and a midwife has a lot of time. A doctor comes to the ward, sees the patient, prescribes medications and moves away. I'm not blaming a doctor. The scope of work of a doctor is like that. Whereas a midwife is a nurse primarily, and she gets to spend a lot of time with the patient. And if you noticed, if you have worked in the ward, patients are more comfortable talking to you, telling you their issues. So in that case, quality of services is better because the nurse or the midwife is there with the patient, giving all her time, all her attention. As my friend over there had said, by introducing midwifery, maternal and newborn morbidity and mortality reduces. Shift from fragmented care to skilled and compassionate and woman-centric care. So the care becomes more woman-centric. We ask her, what would you like to do? How would you like to proceed? We are respecting her. We are allowing her to have somebody by her side. All women are actually anxious when they get into labor. Having someone close to her helps her gain more confidence. Reduces unnecessary medical interventions and empowers midwives as frontline workers, frontline leaders. Every time we learn a lot in obstetrics. We learn OBG, we learn from the textbook Datta. We learn quite a lot of what doctors learn. But how capable are we to take decisions? How capable are we to lead? When you train to be a midwife, they instill in you qualities which would help you to make decisions, plus there is a legal framework to support you. Of course, when you finish your master's in obstetrics, there is no legal framework for you to be supported. Here, you have a legal framework to also support you, saying that this is your scope of work. So in that way, you are more confident, you become a leader, you can take up initiative. And aligns with WHO and ICM guidelines for safer maternal health leaders. That's what WHO says, that's what ICM says, that we should have more frontline maternal health leaders. So now if you look at this statistics, a Cochrane review. So a Cochrane review is basically a very, very high quality review of good randomized controlled trials. Meta-analysis and meta-synthesis is done, and data is collected from studies which are done really in a very high quality environment. And it shows that a midwife-led continuity of care can result in 24% reduction in preterm birth, a significant reduction in episiotomy, instrumental birth, or use of pain relief while increasing psychological support of women. So this was published in the Lancet series of midwives, which said that complications are lesser. Instrumental births are lesser, no vacuum, no forceps, sometimes no episiotomy. The mother gets to deliver in a position that she is comfortable. Normally in a ward and a labor room, a woman is asked to lie down in a lithotomy position. But is that position actually supportive of delivery? When you stand, by gravity, something should come down. You make the woman lie down with her legs up and expect her to deliver, it becomes a little difficult. So in midwifery, we look at alternate birthing positions. We think about different breathing techniques, different support systems to help the mother deliver normally. So I think you should all remember that midwifery-led care units have resulted in 24% reduction in preterm birth. And I think we should all take up midwifery courses and become midwives. So these are some important facts of midwifery that you should actually remember. So, of course, there were certain institutions in West Bengal, Gujarat, and Andhra Pradesh. I think you would have heard of Fernandez Hospital. So they were hospitals who started this full midwifery initiative way before the government thought about it. And then these models were really successful. And after which in 2018, Japaigo, BMGF, and the government sat together and drafted a guideline to initiate midwifery. And the plan was to roll out midwifery in the year 2019-2020. So this nurse practitioner midwives had to be trained in a particular place called as State Midwifery Training Institute. Okay, so that was the plan. And initially the government thought that we should have 6 national midwifery training institutes and they would be able to train the midwifery educators. So this has 2 components. We have nurse practitioner midwives and we have nurse practitioner midwifery educators. So the nurse practitioner midwives need to finish BSc nursing or GNM nursing, work for 2 years in an OBG unit where they have deliveries, antenatal care, postnatal care, and then they take up this NPM course, which basically happens in state midwifery training centers, institutes. In UP, do we have this training happening? In UP, do we have this training happening? My students, are you aware? Yeah, it is happening. It is happening in Meerut, it is happening in Kanpur, it is happening in Lucknow. Okay? Then the nurse practitioner midwifery educators. So for this, what you need to do is you can be a BSc nurse or you can be an MSc nurse, after which you should go for a 6 months training course, which is basically at a National Midwifery Training Institute. It is a residential course. So you do the course, and after which for 1 year you should go to the State Midwifery Training Institute and mentor a nurse practitioner midwife. After which you are certified as a NPME, Nurse Practitioner Midwifery Educators. So the Nurse Practitioner Midwife course is for 18 months. The NPME course is a BSc or MSc, and after which you do a 6 months course and you have to mentor nurse practitioner midwives at the State Midwifery Training Institutes. On this March 8th, on Women's Day, actually a midwifery-led care unit was opened in Dufferin Hospital in Kanpur Nagar. This is just information for you because we all belong to the state of UP. So, yeah. So this is the training cascade. We have recruitment of midwifery educators by state governments. So some of them are deputed, some of them are people who voluntarily say, I'm interested in this. Then we train these midwifery educators at the National Midwifery Training Institute for 6 months. The midwifery educators who qualify are posted in the State Midwifery Training Institute. One more beautiful thing about this course is this is not just like a theory exam and practical exam. They have competency-based assessment to see whether the midwives actually are competent to do what they are supposed to do. After which, training of the NPM trainees by midwifery educators should be done for 18 months, and the size of the batch is 30, and the number of batches per year is 1 batch. The midwifery educators are mentored by the NMTI mentors and external observers. They will be supported. And the trained NPMs are deployed at Laksh certified facilities. Okay? That is the labor room quality initiative facilities. And trained NPMs are mentored by midwifery educators. So the midwifery educators support the NPMs. Okay? And they are posted at the Laksh facilities, certified facilities. So in UP, actually speaking, a working group committee has been established. It is under NHM, and I think UPSMF has provided permanent registration for 5 NPMEs of the UP batch. UPSMF conducted the examination of the first batch of midwifery educators in 1st of May 2024. NMEs, that is nurse midwifery educators, have been deployed in identified state midwifery training institutes of Kanpur and Lucknow. The training of the first batch of NPMs, that is 30 of them, have been selected from Lucknow, and midwifery-led antenatal services are happening at 3 facilities, Lucknow, Meerut, and Kanpur. And there is an MLCU in Meerut, that is midwifery-led care unit. Okay, they are units where they can work. And recently, there is a new MLCU which is established in Kanpur Nagar, which is the Dufferin Hospital. Okay. So now let us see what is the role of midwives in improving the healthcare outcomes. So the first role is to enhance the quality of services or quality of care. I think all of us like a doctor, a physician, or anyone who spends a lot of time with us. Half of our issues are in our mind. If the doctor takes 2 minutes to see us, we don't feel very happy. He may be the best doctor, he may prescribe the best medication, your illness may be cured within 5 days or 3 days. But if the doctor doesn't spend time with you, you don't feel all that confident about the doctor's abilities. Half of our illnesses are in our head. So when we have a nurse practitioner midwife, she spends a lot of time. She listens to a lot of the patient's concerns, lot about her culture, lot about her family, lot about her income status. So she basically has a holistic perspective of the woman, and she is with the woman from the beginning till the end. So there surely would be an enhanced quality of care. There would be improved maternal and neonatal health outcomes because we are going the natural way. Lot of safe birth practices are promoted. We try and let the mother deliver normally. The mortality rates are less, and patient satisfaction and quality of care is enhanced. So let me give you some examples from our midwifery-led care units and our midwifery services from the state of UP. So in Uttar Pradesh, 92% of women in early labor were offered non-pharmacological pain relief measures in our antenatal care services, in our midwifery-led care units. 92%. They did not give them medications. They gave them non-pharmacological pain relief measures. 89% of the women were encouraged to walk during the first stage of labor. When you walk, labor will progress very efficiently. And 98% of the newborns were breastfed within 1 hour of birth, which is very good, which is a good number. And 100% mothers received a uterotonic immediately after birth. When you use a uterotonic, the chances of PPH and other complications are lesser. So these are the service statistics. Midwives have conducted about 3,389 ANC OPDs, which is a good number. Midwives have conducted 351 births till March 24 at Meerut. Out of all the births conducted by the midwives, 85% of births, women chose alternate positions, not the supine position. And semi-sitting position was a position that was preferred by all women. Experience of majority of the women, that is 66% of them, were good. They felt very good having met a midwife, and the remaining said it was 34% of them said it was average. Furthermore, 87% of the women said we would love to come back to the midwife. All of us, when we think of getting married, we all think of, going to good hospitals, meeting good doctors, but midwives is a new, new strategy, and I think we should go to, midwives as well. Yeah. So whenever we make policies in midwifery, things that we need to remember is establish an educational framework at the national and state levels, which has already been done. Ensure evidence generation and knowledge management. Whatever measures we follow, whatever alternative and complementary therapies we use should have evidence base to support them. And facilitate creation of a favorable policy and regulatory environment. If the government, if the top management doesn't support us, if we don't give jobs to nurse practitioner midwives, no one is going to take the course. So these things should be kept in mind. And whenever policy is being made, look at evidence-based practice, look at all the regulations and standards of care, look at the training and education that the educators get and also the nurse practitioner midwives get, and also see to that this particular unit covers a lot of access to care and equity. Like the rich and the poor should be able to be treated in the same line, the same quality of care should be provided. Okay. And there could be a lot of evidence-based policies in midwifery around home birth policies. So wherein we create, because a mother will be more comfortable in a home environment, benefits and safety of midwife-led home births, informed consent and shared decision making and not autocratic decision making, importance of educating and involving women in care decisions, good postnatal care, support for breastfeeding, mental health and recovery of a mother after delivery, cesarean section reduction. Every hospital cesarean section rate is higher. Policy promoting safe vaginal practices and promotion of various birth positions. There should be, for this to happen, there should be a lot of collaboration between our different medical fraternity members. The doctor should accept it, the system should accept it, and this should be integrated into our healthcare system. If it just happens in 2 or 3 private facilities, it's not going to take roots. It should be integrated within our healthcare system, just like Ayurveda, Unani, and Siddha are part of our healthcare system. And we should be able to work very well with the obstetricians, pediatricians, and other healthcare professionals, because there may be complications, there may be doubts that you want to ask someone. If the doctor, the obstetrician or the pediatrician there does not support you, it will become a problem. But though this particular model has a lot of benefits, there are a lot of challenges affecting the success of midwifery in India. So a few of them are role clarity of NPM and their integration into the existing healthcare system. Do we have posts to take NPM? Like we have staff nurse post, nurse tutor post, assistant professor post. We do not have a separate cadre. Of course, it has been started, but not many people are taking it up. So that is a problem. Career progression. If we are not getting jobs, why will we take a job? We need to, at the end of the day, all of us work for money. Of course, passion is there, desire to serve the community is there, but primarily without money, you cannot move forward. So if you don't have jobs, why will I take up a course? There should be legal protection. Actually, nurse practitioner midwives have a lot of legal protection for procedures. For administering drugs, there is a little bit of problem. I mean, they have to get permission from the drug advisory board. It is still in process, so that has to be taken care of. The midwife should be trained properly. For that, we need support from the doctors, the obstetricians, and other midwives. Sometimes in India, we do not have good midwives. We need to get midwives from abroad to support the education of our midwives here. Cultural and societal barriers. We all want to go to the top obstetrician for delivery. Nobody is thinking of a midwife. She's a nurse. She may not know. Regulatory and institutional barriers. We may not be having support from the government for us to take it forward, and resource limitations. So how can we overcome these challenges? The first thing is educating everyone. I mean, I stand in a hall with a lot of nurses. Y'all are nurse educators, nurse administrators, nursing students, undergraduate and postgraduate. But not many of us had an idea of, who a nurse practitioner midwife is. How is she different from an obstetrician? So I think educating all of ourselves about the availability of this course, what is the scope of work, is important. Advocating to people who are sitting on top, our policy makers, principal secretary, our councils, everywhere around would make this, and pushing for this course makes it better. Public awareness campaigns, professional advocacy is something that we should do. Collaboration, please speak to other doctors, ask for their inputs, involve them in our particular midwifery course. And increasing investment, we should offer more funds for this course. So more staff nurses from the government and the private are deputed for this course. So people would like to take it up, and securing funding for midwifery services and infrastructure. Because to set up a midwifery-led care unit, we need separate infrastructure. We need separate equipments and instruments to help with the natural process of delivery. Yeah? So all this has to be facilitated by good funds. So to conclude, I would like to say that it is very important to have evidence-based policies in improving maternal and neonatal health, because there is a 24% reduction in complications with having a midwife around. Midwifery's critical role in reducing risks and promoting healthy outcomes is quite important. And we need a lot of further policy development, research and investment in midwifery care, because we need to work on it, develop it and tailor it to the needs of our country. And I think in all the developed nations, midwifery is a booming area and everyone goes to a midwife in comparison to a obstetrician. So I'm done with the presentation. Thank you. Do you have any questions? So if you don't have questions, probably you understood everything or you didn't understand anything. Yes, ma'am.
So very excellently delivered a session on awareness. I'm very sure the final year students have a lot of learnings. I wish to just state that way back 45 years ago, I did my general nursing, I did my midwifery. That was the starting of my career. We had a 1 year long midwifery that was in the Indian Navy, and we nursing officers managed the entire setup of deliveries, whether a priming gravida or a multi-gravida. We never had an obstetrician in the LDR whatsoever. Yes. They were on a call, and if we felt there are anticipated complications, we would call them. I'm talking of 1977, 78, 79, 80, and this continued for multiple years in the Indian Army setup. Even now they are privileged because they take midwifery in the Army education, a 1 year long program. They are privileged and they are also protected. Yes. And they have the obstetrician for intervention just a phone call away. So somewhere in the private sector, this privileging empowerment has been missed out. In the private, the entire obstetric, simplest of the work, which is a nature's work, has been hijacked by the obstetricians because they can charge a huge amount of money for even a normal delivery, which costs 1 to 1.5 lakhs for a patient, a normal delivery. So I think somewhere this scenario has to change. There are so many good examples in our country. where this is working, and with nurse practitioner in midwifery, the privileging is also there. Probably the country has to wake up to this call. The doctors have so much more advanced work to do.
Yes.
They don't need to just stick to the normal delivery or obstetric work, antepartum time, intrapartum time, and the postpartum. All that can be managed by the midwifery experts. That's all I wanted to say.
Thank you, ma'am. And I think there are some places in India also where OBG nurses still conduct deliveries. They do everything. Only if it is abnormal, they call doctors. Like they just have their regular BSc nursing or masters, and they still conduct.
Entire Indian Army practices
This is that.
Entire, yeah. And I have conducted more than 500 deliveries as a very young nurse. So I think there is no big deal. It is only the empowerment, the privileging, and the legal protection, medical legal protection, which needs to be given. The rest should be in order. Thank you.
Thank you, ma'am.
Thank you for such an informative session, ma'am. Now I would like Sister Maggie Jose, ma'am, to kindly provide the valuable feedback.
Good afternoon to all. First of all, I acknowledge that I forgot, I think I was embarrassed. I could not speak about Ms. Dr. Monica, about her biodata. I forgot completely because I told something about the leader and I knew her personally. So I know she is a very good leader and she had been leading us. So I just got out of it. When I was sitting there, I remembered I have not spoken anything about her. I think all of you must have also felt that. So it was a blessing in disguise, so I will be just saying about her a little bit because the audience may not know about her. I'm sorry for not explaining.
Okay, it's okay, sister. No problem.
Will you please speak this? Dr. Monica Rita Hendricks currently serving as Senior Program Officer at UP State Medical Faculty and Jepaigo, Johns Hopkins University affiliate. Education, ma'am holds a PhD from Sri Ramachandra Institute, Chennai, focusing on neurodevelopmental outcomes in preterm neonates. She earned her master's and bachelor's in nursing from St. John's College, Bangalore. Experience, she has previously held key roles including associate professor, nurse quality coordinator, and consultant at BEMPU Health. Her expertise is reinforced by multiple certifications, bioethics, pain management, and quality improvement. She has many achievements and actively contributed to education and research. Ma'am has guided numerous projects, conducted in-service training, and presented at national and international conferences. She has also organized major healthcare conferences including the 5th National Kangaroo Mother Care Conference 2021 and OSCE Master Training Workshops 2024. Her leadership continues to shape maternal and neonatal health care. So I think let us put our hands together to give ma'am a very good round of applause. It was really an enriching and a brainstorming session. I think many of us will agree that it was a revision for many of us. It was like a tutorial session which gave us lots of information regarding midwifery and what is a midwife and who is an obstetrician. The difference she has explicitly explained to all of us, and she has explained the scope for a midwife, how she can be functioning as a self-independent person and what is the role of NPMS. So all those things are very clearly explained to us, and I think many of you must be having in your minds, maybe I can, after this particular study, I may get into that so that I can work independently with the help of others, but then at the same time, I can be a good midwife caring for the mothers or the women-centered care and thereby reducing the maternal as well as the neonatal mortality rates. And she has also explained about what is the role, what are the strategies that is necessary to bring about that care in our curriculum. So once again, thank you so much, ma'am, for your brainstorming, dynamic and vibrant presentation, which gave us lots of input, and we hope we will continue to practice. Take care of our patients, because we had already morning 2 sessions. One was on related with empathy and human touch, and followed by that we had the technology developmental programs, the simulation based training. So everything is there available for us, but our human touch and then our empathy to patient care is very, very essential, and she has given us one more input session on regarding that. So how we can help young mothers to have their deliveries safely conducted, and how they can be helped, how the healthcare facilities can be improved, how equitable services can be brought about in the both regions, the urban as well as the rural areas. She was also telling about 80% of the population lives in the rural areas and only 20% lives in the sophisticated areas. But our role is to develop those people who are living in the remotest villages where 80% of the population is centered upon. So let us as nurses work towards improving the health status of women and children in our respective areas. Thank you.
Thank you, ma'am. I would like Mrs. Anamika Chaurasia, ma'am, to kindly come up the stage and present our esteemed speakers and chairperson, the memento. Thank you, ma'am.